Hi everyone, welcome to the A Life of Education podcast. Today we're here with obviously Keith and Oliver.
Yep, Oliver Blenkinsop over from the UK. You are the program director for the MSc in Sport Rehabilitation at St Mary's University, Twickenham. Have I got that right?
Yeah, spot on.
And that is the course that you and I both sat together at undergraduate level a long time ago, and now you have found your way to the head of the top of the pile.
Somehow, yeah. Made my way all the way back. Yep.
So do you want to just sort of get a little bit of background of where you grew up, and obviously we were both in university together back in the old days, and then how you ended up sitting here beside us?
Yeah, sure thing. So as you've already alluded to, went to St Mary's University for my undergrad in Sport Rehabilitation. I was very fortunate during my years there to go on placement to the States and experience the collegiate system. So after graduation, I decided to pursue a master's in athletic training over in America. So I went to South Dakota State to do my master's there.
No, yeah, carry on. No, sorry.
Yeah, no, it's
all right. To get you back in camera shot.
Yeah. So I did my masters at South Dakota State in athletic training, and I was fortunate enough to work with the women's soccer team for a lot of my time there, and also experienced some other collegiate sports such as wrestling, American football, which was a really good eye opener for me clinically to see those different populations. And then after that, I was fortunate enough to get a job in the MLS as an assistant athletic trainer for the Seattle Sounders.
The MLS is the Major League Soccer.
Major League Soccer, yeah. So it's like their Premier League of America. Wow. Yeah, so I worked there for 2 seasons. They were very successful during that time, so it was quite fortunate again to see some of that success and experience that, and work with some really good practitioners over there, and that was a really good experience for me. And then obviously now I've moved back to the UK, where I'm now course director or program director for the Masters in Sport Rehabilitation. So kind of come full circle in some respects to end up where I started off, but it's been really good.
So Oliver is, we're very lucky to have you and to do a course for A Life of Education, and your course is centering around rehabilitation. So what are some of the things that people are going to learn by doing your course?
Yeah, so essentially it's going to be an introduction to some musculoskeletal injuries and kind of the processes that we go through to kind of guide our thought processes for the rehab. So what we'll do is we'll start off by, or what I have done is start off by speaking a lot about kind of pain. So there's an introductory lecture on pain, and we don't go as deep as we could do into the pain side of things, but we kind of touch on the tip of the iceberg of pain and how pain can affect the body and affect the rehabilitation process. It's an area that I've started to develop an interest in, or a stronger interest in. So what we do is we recap that. So we go into pain, we talk about how it can affect the person, the physiology of the human as well, and then what we'll do is we'll focus around 3 main areas. So we're going to go into ligamentous, tendons and muscle injuries, give a brief overview of what occurs during that, and then talk about some of the thought processes and research kind of led processes behind the rehabilitation of those injuries. So it takes a very much an evidence-based practice approach for the learner, and hopefully by the end of it people will get a really good idea of the direction that they want to head in terms of rehabbing some of those injuries. And we try to give as many case studies where appropriate. It's never going to cover the whole spectrum of everything that there is, but I hope that at the end of it the reader or the listener will get a really good idea about the processes that they need to follow, and hopefully there'll be a clear structure that they can guide themselves with.
Yeah, I mean, we spoke over dinner last night. We kind of the differences that we're not trying to tell people exactly what to do on this linear sense. It's more just giving them an understanding of the process of healing for different tissues, and then enabling them to create their own sort of programs from there.
Yeah, there's so many ways to skin a cat, right? So I think if you have the underlying knowledge of what's going on from a tissue level, from a person's beliefs, and kind of looking at the biopsychosocial model, if you kind of can incorporate all of those into your rehab, and you understand fully the movements required to stress the tissue to help it heal, then I think there's too many exercises and too many different ways to go around treating it. So I think we kind of hopefully give the listener a really good idea about what it is they need to achieve, but how they achieve that is kind of up to them, because people will take so many different routes, and again, it's so specific on who you're treating, which population you have. So yeah, it's kind of, without going down one specific route, it's just leading them in the right direction, and then they can make their own kind of clinical decisions to get to that final point.
Yeah, we were saying how like there's a big difference between kind of different loading different people in different ways, and it's not a case of once they can do this exercise, then they can do this exercise, and then they can do that exercise, like you kind of said. And the way I find my practice works very well is when you understand the like you said, the movement pattern and the stresses that the tissue is going to go under, then from there it's almost just about being creative and creating like an exercise that bridges the gap between something that's too easy and something that people will be used to, like just changing some slight little position of the foot will increase the stress around the ankle ligaments, or will increase the instability at the ankle, so you can work on the knee. I think that's going to be super important, and that's what I'm looking forward to most, kind of watching the finished product.
Yeah, I'm definitely looking forward to learning, and obviously learning a lot from you. One of the things that what do you think, firstly, important things? So a life of education is really about helping personal trainers and helping yoga people and Pilates people understand rehab a little bit better. So what would you be telling them are essential things in taking a client through rehabilitation?
I think it's really easy to get it right, but it's also really easy to get it wrong, and you can definitely overcomplicate things. So I think my message to them would be, by the end of this course especially, you'll get an understanding of what it is that you can do right, and then you just need to tailor that to the individual that's in front of you. I think we had that great conversation about relative load and what relative load means. So loading an 80-year-old woman is going to be completely different from loading a 15-year-old child. So I think it's really making sure that you tailor it to the person, but also that there's things that the body will do that you can help, and it's almost like guiding the body in the right direction. And I think you can disrupt the healing pattern really easily, and then that can offset people, and then you kind of lose their confidence and their beliefs change, and so it's really easy to get stuck on this downhill spiral with patients. And I think if you can kind of get them to buy into what you're doing, and a big part of what we talk about on the course is education. So educating your patient and talking to them about, I'm doing this because this will lead to this. We're not going to load your tissue because you're still in this phase of healing, or we are going to load your tissue because actually evidence shows that it's really responds really well. And I think that's a really important thing, and I think that's something that they'll be able to take away from the online lectures.
You mentioned earlier a little bit about the psychosocial side of things. So just for people who don't know what that phrase is, how would you kind of explain that to begin with?
So the biopsychosocial model is something that's is well adopted in sports medicine, and obviously it's looking at the biological side of things. So that's kind of relating to anything to do with kind of tissue healing and physiological responses to an injury, and this can be pre and post injury. A lot of people use the biopsychosocial model kind of after injury to monitor the effects of an injury, but it can also be used to see how at risk people are, and to put them into kind of those danger zone categories. So you've got the biological side of things relating to kind of the tissues, the body, the person as a whole, and then you have the psychological, which is obviously dealing with their mindset. So in terms of beliefs, that's the biggest one for me, is kind of what they preconceive the injury to be about, or that injury to be about. So a lot of people have this idea that tendon injuries are really debilitating and you're not supposed to load them and things like that, and so we'll kind of debunk some of those myths throughout the series, and then also the social side of things, so how it affects them from a day-to-day basis. So is it affecting their lifestyle, their earnings, their social life, friends, families, things like that, and I think we'll try our best to incorporate that into all of our case studies to kind of give people a better understanding of the biopsychosocial model. But there's certainly loads of things out there, kind of free resources on the internet that allude to the biopsychosocial model all the time.
Well, just before we started the podcast, we were talking about the effects of the biopsychosocial pain. Maybe you can elaborate a little bit on how that would affect.
Yeah, so and we do this in I believe it's the second session. We talk about the effects of Achilles tendinopathy on a long distance runner, and we put them in the biopsychosocial model. So we map them through each of those three sections and talk about how how that injury will affect each part. So essentially, again, I'll go back to beliefs is a big one. So we have that common thing that people, if they hurt their back, they'll say something like, "Oh, I've slipped my disc," and they haven't really slipped their disc. If anyone knows the anatomy of a disc, it doesn't allow too much movement either way. So there's all these kind of terminologies that people go to, say like, "Oh, I've got my dad's ankles," for example. You've got your own, you haven't got your dad's. And it's kind of installing those beliefs in people to help them understand their pain a bit better. And so for me, that's the key thing, is the beliefs. And I really have a strong interest in the psychological side of things, because I think as a practitioner, it's what you can really affect, especially with your body language, the way you approach people, but also assessing them as well, because you can see the moment someone walks in the door, how they're going to react. If they've got their head down and they're really sullen, then you know that you're going to have to work a little bit harder at that side of things. Whereas if they walk in quite jolly, then you think, right. And especially in children, you kind of got to look at the IQ, so their intelligence, but also their emotional intelligence, so their EQ. So seeing how well they respond to emotions and how kind of in touch with emotions they are can really be of benefit. So
yeah, cool. I mean, one of the things I find with pain is people's words that you kind of touched on it. I don't want to throw in a curse word here, but when people come in and they say like, you know, I'm really screwed, my shoulder is screwed, I have to stop them and say, are you sure? Like, are you really sure it's screwed? Like, because it looks like you've got full range. You just have a little bit of an achy pain when you're, say, pushing it under a load. So, you know, people come in and they say, oh, my back, screwed, done, like, I can't move. And it's like, well, let's just wind it back a bit. Let's really make sure that we're using the right words here. Because there is people out there who are really screwed, and they're the ones who are in wheelchairs and sort of, you know, at the early stage of a post-operation. I think when people use those words, and also when we were in university, actually, one of our lecturers mentioned the language cues about you walk up to your friend who you know has a sore knee and you say, how's the knee? It's not how's your knee. It's how's the knee. Like, it's a not associated part of you anymore because it's injured. Which I think when you're aware of those words and your language that you use, it can really reframe people's position on, okay, look, you're not that bad. Like, let's turn your mentality around. Let's get you a bit more optimistic about this. You're not that bad. There's a lot of stuff you can do. Let's focus on what you can do, not what you can't do for now. So it'll be good to see kind of where with the whole pain, because one of your lectures is specifically on pain, isn't it?
Yeah. So as I said, it's kind of that introduction to pain, and kind of just only getting the tip of the iceberg in relation to it.
I love the whole idea. I have my own theories about pain. Obviously, none of them are scientific, but all just, well, they're all personal. Like, I don't want to diverge into this topic too much, but on a personal level, just experiencing all degrees of pain, I have a feeling that a lot of people are very fearful of their own pain, and instead of experiencing it, we like to, before we approach any level of pain, we like to medicate it straight away. And I know a big lesson for me was to like actually go, okay, well, let me see if I can feel this and I can see what's happening and why it's happening, and if I can actually withstand it, and let's see what happens. And my personal experience, remember, none of this is scientific, is just I really think that your body protects itself to such a degree that it will not allow you to feel a level 10 of pain. It will release its own kind of like lovely like pain neurotransmitters and chemicals, so that you don't experience and feel all of that, so that you can survive to a degree. That's my personal.
Yeah, well, I mean, no one's gonna. Do you know Caroline's story? I think we spoke about it briefly.
Yeah. You told me.
So pretty bad accident.
Yeah.
However many years ago, we can assume she was in a lot of pain. So she's speaking from that position.
Do you know what's really interesting is when I actually had the accident, I didn't feel any pain at all. And that was very interesting because I was totally smashed up. And a lot of the time in the hospital, I would have to, every few hours you'd have obviously attached to a morphine drip and given copious amounts of pain medication. And it really took me a lot of like courage to go, well, actually, I'm okay right now. I'm just going to experience this and see how far I can take it. And I feel from a personal level, I was really afraid of that. And I think educating yourself about pain, it can change your perception about it and can maybe, it's interesting. I'm going to
for anybody listening
about that.
No, I was just going to frame it for people, anybody who doesn't know. You just in summary, two and a half years ago, had a rock climbing accident and fell from 7 meters, broke a lot of bones in your feet, broke your hip, broke your back, pretty much laying there broken, in a lot of pain. So just for anybody who doesn't know what Caroline's story is.
But what's interesting is that I wasn't in pain. So this is why it's so, and obviously you can explain this to people a little bit more.
And we do touch on that in that we relate it to a lot of different stories, because there's a lot of I mean, I guarantee you that everyone out there has had tissue damage and not had associated pain with it at some point. And I mean, a paper cut's a prime example. You don't know you've got a paper cut until you see it. And I think we go into detail on sunburn as well. Sunburn's one of those classic ones. You experience sunburn on the back, so there's clear tissue damage and something's occurred that's changed the state of your normal tissue. But you don't experience that sunburn until you either lie down in bed at night or you go and have a shower, and there's a different mechanical input there that then makes your body aware of this. And we touch on the pathways of pain and how the brain can decide and determine what it wants to experience, and how it deems what's more important at that time. And potentially in your case, your body decided it's not healthy for me to experience pain right now. I need to survive, and let's focus on that. And there's loads of wartime stories of people having limbs blown off, unfortunately, and not experiencing any pain because they understand that there's more important things, so to put it, and they need to so it's really clever. And that's hopefully the biggest take home message from that first lecture is that pain is created by the brain. Pain does not exist outside of the brain. Pain isn't an input to the body, it's only an output from the brain. And hopefully that's the biggest take home message, and even that message to patients can really help them understand pain as well, because I think the biggest issue with some of the patients is that they associate pain with tissue damage and harm.
Massively.
And so making them understand that pain's protective, so experiencing pain is good. It's never a bad thing, and I don't think you should ever make them feel like their pain isn't real. That can also be a very dangerous message. Their pain is always real. It's just not always associated with tissue damage, and that's not necessarily a bad thing, because pain can be created to protect you as well. So it just makes you aware that either someone's pathologically in a state, or they're protecting themselves, and that's where we can get into kind of the movement side of things and push them into pain. And hopefully again they'll get a better understanding of how we can work pain and work into painful areas to help decrease and desensitize the body.
Yeah, so that's a really good analogy and a good segue, the sunburn analysis, because I had an experience when I was working with the military guys where I was trying to find a way of the difference between tissue damage and pain, and the brain realizing that the body is sensing pain, and the difference between if we keep going, you're going to cause more tissue damage. And they used to feel a lot of pressure through their chain of command, that when they would have a sore back, they'd go to the docs, they'd tell the docs they're sore, they'd get time off work, and then the chain of command would make them like, okay, you got to stay and work. Like, I need these boxes moved. We need these people driven across the country. Like, you're going to be the guy who drives. And the soldiers, to tell them, I can't. My back is sore. Like, you're going to make it worse. And we get to the point where they'd go for a scan, and the scan would come back with a nice intact spine, and there's no disc, there's no whatever. And they'd come to me going like, Keith, I'm in pain. Like, the scan came back clear. What can I do? Like, everybody thinks I'm making this up, and that's a really bad position for a soldier to be in. It looks like you're taking the easy option, and you're just trying to get out of work. So I used the sunburn analogy that, look, there's nobody saying that you're making it up or it's in your head. That's what they were saying, and I think that language again is very important, because what you're describing is it is in their head, but the term "it's in your head" indicates that they're fabricating it, not that their brain is feeling it. So there's a real little kind of muddle up of those words that people say the pain is in your head. the person thinks they're being accused of fabricating the pain. And the sunburn analogy that I would use with them, that I used with this one guy who came into me, and I could see he was a sergeant. He was getting pretty upset like about this situation. And he said, I told him, you have a shower every day at a certain temperature, and you go out that day and you get sunburned. And you get back into the shower at the end of the day and it feels like the water is burning your skin. But you know that from your everyday that the water is not causing any tissue damage. But the nerves in the area now are super sensitive and they're protecting your skin from any possible threat. I said, so when we're moving around in the gym and you're feeling pain, we're not necessarily causing more tissue damage, but we are triggering the nerves to tell the brain, be careful. And it's manifesting in the head as pain.
Yeah, I think sometimes that, sorry to interrupt you, that has a lot to do with the state of your nervous system. So
Absolutely.
being in like
stressed.
Being super stressed.
That's where that biopsychosocial model fits in as well with the other side of things. And we talk about, we take a great thing from David Butler in the course, and he's really good at this, and I really like his way of thinking, which is why I've used it in the course. But he talks about the dangers and safety within you. So there's been things where even like the smell of coffee can help relax people, but also at the same time that might make you stressed out if you don't like coffee. So it's really interesting. And that also leads on to the whole scanning thing, because that's kind of a big problem I think that we have nowadays, with especially with high performance teams that have the money just to send someone off and scan. It can work in completely the opposite way, whereby someone comes in with hamstring soreness, and again we'll talk about the levels of hamstring soreness and how it relates to tissue damage, and they might get their hamstring scanned, and for anyone that's kind of worked in this environment, they'll understand that these people are hypersensitive because there's a lot of money involved in it,
and pressure.
Yeah, and they want to protect themselves as well, because they understand that, a hamstring injury, God, like the reoccurrence rate's high and I can miss a lot of time if I don't do this right. So scanning can be really bad in that respect, because if they've only got, say for example, a type 0A or 0B, so your typical DOMs, and they feel soreness and they've had a hamstring injury before, then all of a sudden they become in this protective state. You scan them and it shows some scar tissue or some residual damage based around something they've done in the past, and all of a sudden their pain increases, and all of a sudden they become too protective. So scanning is definitely a big issue, I think. I think we're starting to lean a bit too heavily on scanning as clinical diagnosis, and there's some situations where it's vital to scan, certainly. But I think the readiness of it and the availability that we're having can be quite damaging.
That's a good. So then, how would you advise a PT or a yoga instructor or a Pilates instructor who has a patient or a client presenting them with pain and a scan, and either the scan is giving them information that says they're injured, their disc is bulging, or it's saying there's no injury, but I'm in pain. How do you recognize that as a PT who's not got a wealth of experience in injuries?
Yeah, well, first of all, obviously, when that scan comes through, always follow the advice of the doctor. I think if there is a clear injury and it's been caused acutely, then treat it as appropriate and as told to, so follow the guidelines. But I think if they come in with a bit of soreness and they say, should I go get a scan? Again, make sure you're doing everything within your remit. So just find out obviously what they've done. It goes back to the relative load. Say for example, a Nordic hamstring curl, it might be very low load for you and it might be very high load for me, and so therefore after that it's the same exercise, yet I'm probably going to experience pain, so to speak, or soreness the next day. And I think again it goes back to educating the patient and understanding what relative load is to them. So how you load them is really important. And if you educate them saying, well, you're going to be really sore tomorrow, then they'll expect that and it won't come as a shock, and you can educate them. But in terms of if they came to you with a scan that showed something pathological, then again, that's a really tricky situation. That's where you need to kind of communicate with whoever had the scan or performed the scan, or the doctor that referred, just to get the full story, just to stay safe.
Yeah, I mean, for me, I have a good amount of experience, not so much with the scan, because the scan is obviously observed by the skilled, is it a radiologist or the MRI technician? I can't remember what the term. They write the report, and from the report, everybody kind of follows the lead. But some of the words they use are pretty confusing. They're pretty tough, and they use different words for the same thing sometimes. So I think from my perspective, my advice, if anyone wants my advice, would be to send a direct email to the physio. Find the info from the physio or the doctor and contact them and say, look, this person has come to me and we have this ongoing issue. Can you direct me as to what I should or shouldn't do? Physios really appreciate that. Physios think, okay, well, here's a standout person who knows their remit and they really want to help, and they go on that extra bit for the client. But I think what you said is important, that you have to follow the chain of command above.
Yeah, and I think after the course as well, we'll touch on musculoskeletal injuries, and we'll give timeframes behind, or typical timeframes. Again, these all change relating on to the person and the circumstance. So we'll give rough timeframes of when things will be healed by, and when we can start progressing our return to play or our exercises. So from that respect, I think you can still be educated enough to not have to lean on the people above you. In respect to, right, I know that this tissue should be healed within the next week, and we can then progress on to doing concentric eccentric, so we can move from our isometrics to our concentric and eccentric exercises. And I think, again, the patient will tell you a lot. So just if it's symptom led in response to pain and dysfunction, then the progression can be really simple. Is do you get pain on an eccentric contraction? Then yes, then maybe we'll just stay with isometrics for another day or so. So certainly lean on the people above you, but at the same time build that confidence with your patient through education, through letting them know that, you know, you've experienced a grade 2 tear of your muscle fibers. It's going to take this amount of time to heal. This is our time frame. This is what we're going to work towards. But don't put too much emphasis and too much pressure on them following that, because things do change.
Yeah. So that, I mean, it's almost like we're talking about just muscle tissue, which I think is relatively straightforward. Like you said, like some people will just heal by themselves. You know, they'll just get better. The high-end elite athlete needs a lot of care and attention if they're going to reach that high-end performance again. But in relation to someone just kind of presenting with back pain, you know, like everything hurts. Even when I'm not exercising, I'm in pain. Getting in and out of the car is in pain. Like, how would you advise someone in that realm who's gone to get a scan, or they're on the tipping point of, should I go get a scan or should I not? Like, what does a PT or a yoga instructor or Pilates instructor, what advice do they give? Or what do the people who are listening who aren't in that profession, they just wonder themselves, should I go get a scan if my back is sore, or can I exercise, can I push through this, or should I just, you know, should I pull my bootstraps up and get on with it?
Yeah, without giving too many spoilers for the course.
I think that
yeah. I think certainly, like, I think what we'll do is educate people on pain, and kind of, and it goes back to that biopsychosocial model. So they could almost take a sit back and go, well, what's gone on when I've experienced this pain? What is it? Is it I've got a phone call from my mother-in-law? Has that all of a sudden, am I now in pain? Because she could be the stressor, for example. Or is it that, you know, I've just got a really stressful email from work and all of a sudden I'm now in back pain? So they can look at themselves, they can almost self-reflect on when their pain comes on. They can also do things like, well, what have I done recently? Have I overloaded the tissue? Was there an acute point? So did it just gradually come on, or was it, you know, I went to go pick something up and all of a sudden my back went into pain and spasm? And I think it's really important to get it checked out depending on the symptoms. If you're getting kind of referred pain, then I would always go and see someone. But yeah, I don't think that's a really hard one. And again, it depends on the demographic of person you're talking about. Because if you scanned someone over the age of 30, for example, they're relatively going to have their back might be going through stages of degenerative process, but that might not mean that they have to be in pain. But again, if they see that, then that might kind of go, well, you know, my back's crumbling away, I've got bone on bone, all these common kind of languages that aren't really true. And then they start to build up their own belief around their pain. And it's important to,
I think, sorry to interrupt you, belief and attachment to it. Because I think this is what I say a lot, once people become attached to, oh, I'm injured, I have this, that they don't ever move beyond that, and they can become attached to that, and that in itself can be a reason why it continues.
Yeah, certainly. And I think we touch a lot on that, and that's where this course will be really helpful for people, because it will be an education tool, and something that they can pass on to their patients. And I mean, that's the whole thing, is that I feel like the beliefs around certain injuries has just been kind of just, it's been heightened so much that they're made out to be a lot worse than they potentially are. And people, if they get those beliefs in their heads, then it can be really hard to bring them back from that. So it's a really important thing.
I remember being in hospital and a friend giving me several books. One of them was You Are the Placebo. And I remember reading that and reading all of these stories about people who were either in immense amount of pain and were given placebo drugs, or vice versa, where they were normal and they were given some particular medication or tool, and then they were in a lot of pain, and using those like little tricks to be able to get in and out of pain. That was really interesting, because then I started to use it myself to be able to modulate, okay, well, am I really in pain? What's going on? Et cetera, et cetera. So I think going back to the education part of it, books like Explain Pain and Evolve Your Brain and You Are the Placebo are really good avenues for people to help them, if they're in pain, understand their own pain, and then also help their clients or their patients also understand their own pain and what their body's going through, and maybe some things and tools that they can use to come out of that.
Yeah, definitely. Those
just
books.
My tidbit.
Yeah, no, those what one you said? You Are the Placebo. That's a Joe Dispenza book.
Yeah, it's
and
amazing.
What's the Explain? We were you have Explain Pain. We looked at it last night.
I've got it on me today. Explain Pain. Yeah, that's the David Butler and Laura Mosley book. Yeah, I think that's a great one. And as you said, touching on kind of the modulators of pain, and how there's been some brilliant studies out there that have, tricking the brain essentially is what they do. And I mean, associating an input with something auditory or something visual, so playing a sound or looking at a different coloured light. There's been a lot of things around that, and I know Tasha Stanton's played around with sound and back pain, and how you play people a creaky door noise when they're having a pressure applied to their back, and all of a sudden it heightens their perception of what's going on. So it's really interesting, I think, playing around with some of those things.
Smell as well.
I was going to ask, what kind of tricks did you do? What was it, your little...
Well, initially... And this is going to sound really silly, but initially in hospital, my heart rate was, whenever someone tried to move me, to move my leg or to move anything, my heart rate would obviously was strapped up to 1 million monitors so you can see everything, would just go through the roof. And I remember, so some of my friends started reading to me, and as soon as they'd read to me, like my heart rate would drop. I was in no pain and I'd fall asleep. And then I'd wake up, someone was trying to do something else, and the same thing would happen. So that's something that I used initially to help. And that was at the very beginning stages. After that was things like being warm. When I was cold, everything hurt a lot more. And when I was warm, I was a lot nicer. Well, in less pain. So they sound really silly, but when you're in a place where you're in a hospital bed for the next 3 months and you can't do anything, they make a huge difference to the quality of your life. And I'm sure for a lot of people out there, it can be really silly. Like, I liked tea, like peppermint tea, and when I had that, I was not in any pain.
There's some really great new things coming out there to do with like hospital settings and tricking the brain with visual inputs. There's a new system out there called, I think it's Snow World or Snow Globe. I'm not sure if you guys have heard about it, but they're putting VAR headsets on kids with severe burns, and whilst the nurse is dressing the burns and the wounds, they're playing a game via the VAR, which is in a snow-based world, and the snowmen around and things, and
wow.
And it's being shown to dramatically decrease the levels of pain that these children are experiencing.
Why don't they do that with adults? I
yeah,
was someone
well,
gave me that.
that's the thing right now. Given the way we're moving in terms of technology, it's only going to be a matter of time before we start playing around with people's vision to help address the symptoms, and it kind of leads on to an area of research that I'm doing at the moment that I'm interested in terms of tricking the brain and using visual inputs to change how people perceive what is going on. So I think it's really interesting. It's something that will just keep going forever and forever. I don't think we've expanded into that area fully yet.
What's the research that you're doing?
So I should introduce that. So we're looking at the effects of mirror box therapy on acute ankle sprains, and what we're looking at is are we able to affect range of motion and pain levels, and we're also at the same time doing a little test to see how their left and right discrimination, so how good are they at identifying a left or right ankle on somebody else or via a picture. And we're looking at that and looking at the outcomes, and we're still in the stage of kind of like data collection at the moment.
So what's the aim? What are you trying to do? Why would you look at someone else's ankle?
So, mirror box therapy, as you probably know, working within the army, has been used greatly with kind of amputees, people with phantom limb pain, and people with chronic regional pain syndrome. So, what we're looking at is, can we affect people with acute injuries? And there's not been too many studies done with mirror box therapy in acute injuries, because essentially the symptoms are very similar in terms of pain and range of motion. So what we're trying to do is see that can we have an early effect on range of motion, and can we restore that early on? Because if it's not really affected, or it's not rehabbed properly, then people can obviously go into chronic states of pain, but they can also get chronic ankle instability. So if we can work into those ranges early on and we can decrease the pain, then I think it will just enhance our rehabilitation process. It's just another tool.
So just touch on exactly what is mirror box therapy. Like, why would you use that ever?
So it kind of is what it says on the tin. It's a mirror box, and so what we have our participants doing is putting their leg into the box, their injured side into the box. So then what they can do is they can lean and they'll look at the mirror and see their unaffected limb, but it will be in line with their affected limb. So it will essentially look like they've got
your injured limb is moving.
Yeah. So then what we'll do is we'll get them to move their uninjured limb whilst looking in the mirror, so it looks like they're, say for example, my right side's my injured side. That will be in the box, and I'll look in the mirror and I'll see my left foot's the one that's actually moving, but I'll look at the box and it'll look like my right foot is moving. And again, it just tricks the brain to just show, I'm moving that ankle and I'm not in pain. So hold on a second, this can only be good. And as I said, we're still data collecting, but I think at the moment we're finding some pretty good results in terms of range of motion. We're able to increase the amount of motion that we can get at the ankle in those chronic, in the acute ankle sprains.
So what would it look like? You would do a test on the injured side, check the range of movement, put them into the box, move the uninjured limb for an amount of time or patterns, and then retest the injured side, having it done nothing.
Yeah, so the participant, when they've decided to partake in the study, come in and they do a laterality test first of all. So we've got an app where they see 50 photos of a right left foot, and they're kind of orientated funny in space, so they can be twisted around. You can be looking at them from the bottom, from the top, and
or hands. Like
the hand ones are funky, but
They're
we
really
really focus on the foot for this one because it's their injured limb. And so what they do is they have 2 seconds to click either left or right, and at the end it gives us a score of the accuracy and the speed between the left and right. Because what they found in chronic patients is that they find it really hard to distinguish the difference between left or right. And I mean, this can be as simple as they look at a magazine and they see just a leg or a foot in a shoe commercial or something, and they can't tell if that's left or right, because what they tend to do is focus in on the injury, and the brain has a really hard time between distinguishing. And so what we're going to do is look at that in acute injuries, and I don't expect to find anything from that.
Sorry to interrupt you, is that because of, like, say, neural what do they call it, smudging, so that your brain's not able to map the injured side as well because it's not moving it and it's not...
Yeah, exactly. And we talk about smudging and kind of how graded motor imagery works, but yeah, it really has a hard time of... Essentially it's slow at processing down. So if you put your right hand out, or I look at your right hand, my brain goes, right, that's a right hand because I can see my right hand here. But someone who's in chronic pain, it takes them a little bit longer, so they put it out and their brain has to go through the process of putting limbs out there to see if it matches.
So what's smudging?
Maybe you can explain it a little bit better.
Yeah, again, it's just that process of the brain just takes a little bit longer to identify the limbs. And I mean, I'm no expert, and I don't really go into it too much in the course because I don't properly know how to define it, but in my head, and the way that I would probably explain it is that your brain just takes a little bit longer at identifying the limbs because it goes through this process of mapping it against what you experience.
Can you explain it?
Yeah, you might be able to explain it a bit better.
Well, for me, I think, so obviously in your brain, you have certain sections of your brain that specifically, and when we say map, they almost are the sensory areas for the brain to perceive sensory input from, say, your hand. And then you've got areas that actually elicit movement or output from, say, your hand as well. And those areas, when you don't move them, they're not mapped as well. So imagine that we're looking at Google Maps of Dubai, and Google Maps hasn't put the satellite over certain areas, and so those areas, you go down that road and it's like there's no road there, so it's smudged. So the same thing happens to the brain when it's injured. You don't use it as much. It's the sensory definition is less, and its ability to coordinate movement and output is diminished. So it's not as accurate and it's not as fast. And because of that, we tend to phrase it as neural smudging. So that area becomes, it's just like when you say your right hand and your left hand, but you use your right hand a lot more, so it's mapped a lot better. And your left hand, you might use it less, so it's not as coordinated. If you try to write with it, you can't write as well, or you can't catch a ball as well, because it's not as mapped as accurately as, say, your right hand. So that's how I would explain it. I don't know.
I think that was explained a lot better than what I said.
Well, I was going to take it right down to my experience as well, like touching on after what you said. The kind of difference between when somebody rubs something sharp on your skin and then something soft, can you tell exactly what that was? That's a sensory aspect of it.
Well, if you go back to the sensory and the motor, you've got obviously the frontal cortex that does the motor cortex that maps all of the movement and the output. But I think when you're talking about sensory stuff, we call it graphisia, where it's like, say I was going to write the letter 8 on my foot or on my hand. Do I know that that's a letter 8? Can I differentiate between a sharp and a soft object? Do I know that this is a spoon or a fork or things like that? And the better able you are to decipher those things, the better mapped those areas of your skin or are.
Yeah, that comes from the brain, or those receptors sending a signal to the brain, and the brain identifying what it is. So when you're talking about smudging in the ankle, from an ankle injury, it's that the brain can't really understand where the joint is. It's not getting a clear delivery of signalings.
Yeah, so when you look at like the GMI processes and kind of how you progress on to the next stage, you kind of want it to be, you want to be able to decide or decipher if it's left or right limb, and you want to be able to do that within 2 seconds. That's kind of how quickly your brain should work. But yeah, so what we're doing is we're looking at that. And again, I don't, because of the fact that they're all acute, I don't think that they should be too much, or there shouldn't be too much different or lag time between kind of deciding.
Is that the findings that you found?
So far we haven't, I don't know, we haven't statistically looked at that, and as I said, we're still data collecting, so it's a bit harder. There's been some occasions where people have been a bit more or they've been quick on their injured side and uninjured side, but so far I don't think we're going to see a difference in that, which is fine. I think that might be a good thing. It might indicate that they're not in chronic pain, which is good. But yeah, so then we then get them in and we do a simple knee to wall assessment, so just to test range of dorsiflexion, and again, this is prior to all of this, we've ensured that they can walk in, they're weight bearing, so they haven't had any surgery. They won't require surgery on their ankle. And then what we do is they either go into the control first or the study first. So they'll either be blinded, whereby we do the whole process, but with a towel over the mirror box. So they'll either do that first, or they'll do the actual intervention first, whereby they receive the full mirror box treatment. After each intervention, we grab them out, we retest their range of motion, retest their pain measures. We just use a simple VAS score for the pain, and then they're off on their way. So it's a nice, quick study, and so far I think we're finding that it is increasing range of motion. And even if you do the blinded study and then go do range of motion, you're not getting the same increase as you are with doing the mirror box, because we were worried that obviously the more time you spent doing knee to wall, the better you'll become at it. But so far that's not the case. So yeah, it'll be interesting to see when it all finishes up. So hopefully we'll have some kind of good figures by the end of this month, I believe. Yeah.
Nice.
Cool. So moving forward then, where are you hoping to take your career? I mean, we kind of spoke that you've got an interest in pain, and it's kind of like a little thing you want to explore further.
Yeah, so it's still very new to me, but it's definitely something that I find interesting, and I think that's probably a good thing that I find it interesting. And I think that now that I've identified that I like pain, which might sound quite weird, but it's kind of, I think that's good enough for me to say, right, I'm going to follow that and kind of get a little bit more involved in some of those things. So certainly really new to it all, but do have a keen interest in kind of talking about how we can learn more about pain and bring it more into kind of the clinical setting. Certainly.
Okay, cool.
Amazing. Oliver, thank you so much for coming on today.
No worries, thanks for having me.
Yeah, it was a pleasure. Look forward to seeing your course. Just do a quick run through. So the course is actually, it's going to have an introduction to pain to begin with.
Yeah, so I'll introduce pain, and then what we'll do is we will go straight into tendons. So we'll talk about the pathology of a tendon, using examples, kind of your thought process behind that, and then we'll talk about ligaments, again going through the healing times and the grading systems, and then on to kind of the thought process behind the rehab, and then finish it off with muscles, following exactly the same process. So it should be quite structured in that respect, that hopefully on each of the ones it follows the same kind of introduction, clinical presentations, and then clinical thought process behind getting someone back.
Awesome, look forward to it.
And Oliver, if people want to follow you, how can they do that?
Yeah, I've got a nice Twitter account which I'm not too active on, but don't mind being contacted via. So that's just Oliver.Blenkinsop. That's my Twitter handle. Yeah, so find me there.
Amazing.
Tweeting away. Yeah.
Thanks so much, guys. Bye.